chromosomes, third one non-chromosomes, and the last one rapid growers. The first one produce colorful pigments, but they do not show their pigments unless you expose to light for 2 hours. What you should do is to incubate them for 3 weeks, 4 weeks, and then remove it from incubator and check whether the colonies are colorful or pigmented or not. If they are not pigmented, then you put them under lights for 2 hours and return it back to the incubators. And the next day or the same day, you check it again.
It will be pigment.
Exposure to the light causes photoreactivation of some enzymes. They produce some carotenoid pigment. Carotenoid pigment. We call it photochromosomes. Among them are Mycobacterium or M. kansasii, M. marinum, and M. simiae. Kansasii and simiae cause mainly pulmonary infection, but marinum is a disease transmitted from the fish to human.
From eating raw fish?
From aquarium or from the sea or rivers. So the fins of the fish may be infected. If you accidentally damage to your finger or foot, it is transmitted and causes tuberculosis in skin or granuloma. Swimming granuloma or pool granuloma. The first one, M. kansasii, causes pulmonary infection as well as infection of soft tissues too. Marinum grows at 30 degrees only, not at 37 degrees. Simiae is very complicated. It is similar to tuberculosis, and treatment is very difficult. So the anti-TB drugs are useless against these organisms. Doesn't work. The second group is scotochromosome. It means that they always produce carotenoid pigment in dark or in light, doesn't matter. Group 1 and group 2 are slowly growing. It means you should wait 3-4 weeks to see the colonies. In group 2, we have M. scrofulosum. M. scrofulosum causes lymphadenitis in children, in particular cervical lymphadenitis. Another species in group 2 is M. zulgae and M. gordonii. They cause infection in lungs and also in soft tissues. The third group are M. avium, M. intracellulare, and M.
ulcerans.
The most important one is M. avium. M. avium causes disseminated infections in people with HIV. Very important among HIV patients. Then
So,
the number of CD4 plus comes down, CD4 lymphocyte comes down. We have opportunistic infection with this group in some populations.
so is it attacked, especially the HIV patients, right?
Yes. So they are non-chromosomes. They do not produce any pigment, either in dark or in exposure to the light. The last group are Mycobacterium fortuitum. So these are rapid growers. It means that they can grow much faster than M. tuberculosis. You should expect in the primary culture of M. tuberculosis complex to see the colonies in 4 weeks, 5 weeks. For this group, what you should do is waiting about 10 days. So this group, the rapid growers, it takes time, about less than 10 days. sometimes 6 days, 7 days. It depends on the volume of inoculum. So these two mainly cause infection of catheters, infection of soft tissues, in some occasions also respiratory disease too, pulmonary disease too. This one in particular.
The tuberculosis is not from the rabbit growth.
It's not.
From the rabbit growth.
Tuberculosis is slowly growing.
Slowly growing.
Tuberculosis takes at least how many weeks?
4.
4.
4 weeks.
In solid medium. In brass medium, it
5
takes.
to 12 days.
No. In brass medium, it takes 3 weeks. 15 days.
Oh, it's 5 days less.
Okay, 5 days less. Okay, about this group, you can see the M. avium complex. This is in Moray books, your book. And this one also is from your books. It is blood, I think, from tissue from a patient with AIDS. These are acid-fast bacilli. See, these are acid-fast bacilli, Mycobacterium avium. Mycobacterium avium has several subspecies. One of them causes infection in people with AIDS. The other one causes disease in the birds. So, this is an avium. About this group of organisms, you should know that person-to-person transmission is not happen in this group. So they are not highly contagious to humans. It is not happen, it is not transmitted from human to human in this group.
From animals?
These are mainly environmental exposure. It transmits from the environment to us by aerosols produced in the air, in the soils, and also from the water aerosols. Okay, so follow your slide yourself because I need to come back to treatment and control also is different from tuberculosis in this group. And then Mycobacterium leprae. This is the last Mycobacterium we discussed.
Lepra.
Leprae. Jozam. We talked about Jozam. Remember?
Yesterday or today?
Sorry?
Yesterday or today?
Yesterday.
Yeah? Or today lecture?
Today lecture. We talked about Jozam before too, but this is specific for leprae. We have immune reactions. Some antigens from M. leprae cause damage to the nerves. Actually, these antigens produce antibody in human body, and these antibodies cause neuritis, inflammation of nerves. As a result of damage to the sensors of the nerves, people with leprosy has local anesthesia.
Is it the inflammation that's happened to the new babies when they vaccinate with a special vaccine?
No. It is just prolonged contact of the people with leprosy with other people. In this way they transmitted. We don't have any vaccine against leprosy, and BCG cannot protect against leprosy too. The vaccination with tuberculosis doesn't guarantee immunization against leprosy.
No, I mean it's happened like a side effect for some vaccination.
No. Quite different. This is auto-antibody productions against auto-antigens.
I remember that I read about some inflammation that also happened in the peripheral nervous.
It is different.
Yeah.
This one is different mechanism.
Yes.
Okay. We have two forms of leprosy. polar lepromatous leprosy and polar tuberculous leprosy. In polar lepromatous leprosy, the humoral immunity is active and a lot of antibodies are produced in the body, and these antibodies are not protective. In tuberculous leprosy, cell-mediated immunity raised against lepromin antigens. As a result, we have granuloma in tuberculous leprosy. The gross temperature for this organism is less than 37 degrees. So we mainly see the lesions in the cooler part of the body, such as nose or skin. About the generation time or replication rate, look at the slides, the fourth paragraph. It takes 10 to 12 days to replicate, to divide. So, we don't have any scientific culture medium to grow it. What we have in our centers is to grow the organism inside the body of armadillo and mouse pipe. Also, there is a monkey in Africa can host this organism. It can grow in this monkey to a special monkey. Beyond this, we are not able to amplify this in the laboratory. So tissue culture is useless, cell culture doesn't work, only animal inoculations, armadillo and mouse. The body temperature of armadillo is less than 37 degrees too, so it can support the growth of this organism. Armadillo can transmit the disease to human too. About the organisms in people with leprosy, look at the figure, this one. 10 power to 10 bacilli in 1 gram of tissue. Huge number of bacilli. In practice, you have slides to see. When Dr. Amy comes to show you, look for the slides for leprosy to check. So it damaged the peripheral nerves, and tuberculous leprosy is characterized by self-healing granulomas containing only a few, if any, acid-fast bacilli. Because of this, they nominate lepromatous leprosy as multibacillary form, means a lot of bacilli presence, and we call the other form, tuberculous leprosy, as paucibacillary form. In tuberculous leprosy, sometimes we cannot find any bacilli in the lesions. How we can recognize tuberculous leprosy, to be sure about this?
Can we take a tissue sample?
This is one. The another one is?
Serum or other bodily fluids.
From the, maybe from the saliva? Saliva?
No. To ensure about the immunity of the patient, whether it is tuberculosis or lepromatous, is to use PPD from M. lepre.
PPD. Purified
Protein derivatives prepared from M. lepre. They call it lepromin test. Lepromin test. If you inject lepromin to the arms intradermally, after 72 hours, you should check the injection site to see whether it is red or inflamed, indurations happens, and also the body temperature increase or not. If it is positive, that means that it is tuberculous leprosy. Why? Because cell-mediated immunity is active against leprosy. This is intradermal lepromine test. Okay? In both tuberculosis and leprosy, cell-mediated immunity is important. In cell-mediated immunity, we have two sets of lymphocytes, CD4 plus and CD8 plus. Also, we have T helper 1 and T helper 2. If T helper 1 increase and is active, then cell-mediated immunity is active. So you have tuberculous leprosy. On the other hand, if T helper 2 is active, the body starts to produce antibody. So humoral immunity is active. Because of this, we have tuberculous leprosy, lepromatous leprosy. In lepromatous leprosy, antibodies goes up, but these antibodies are not protective. In tuberculous leprosy, cell-mediated immunity is active. So
T-cell mediated.
see in this slide, here cell-mediated immunity is active. The number of bacilli is just 1 plus on the top. We call it pulse bacilli. And on the bottom it says tuberculous. This is tuberculous and this is lepromatous. In lepromatous you can see the number of bacilli is 4 plus. 4 plus. Here, humoral immunity is active, so antibodies has gone up in this group. And these antibodies are not protective. They are not protective. In the middle, we have borderline. How we can recognize the borderline? By lepromine test. You can change the chain. Are you sure?
Yeah.
And these are some pictures of leprosy. You can see this one and this one. This is mid borderline leprosy. This one borderline lepromatous leprosy, and this one also leprosy. So you have chance to see the colorful atlas of pathology, to see the histopathology and also infectious disease. About the number of cases in the world, it says total number is more than 10 million cases in the world. It is in Asia and Africa. 1/3 of the cases are in Africa. Human to human transmission happens if prolonged contact happens. So two people should closely sit together and have physical contact for transmission. However, it can be transmitted by insect bites or inhalation of M. leprae and deposition on respiratory mucosa. So, if I ask you what are the route of transmission of leprosy, you should write about the possibilities of transmission. What are they?
The different kinds of transmission.
Insect bites, inhalation of the labor, and deposition on the respiratory mucosa.
Okay. So there are several options. So our routes to explain.
Skin penetrating and wounds.
Yes. Okay, read about this slide yourself because I want for diagnosis. For diagnosis, what are the options? Histopathology is very important. So taking especially from the tissues and staining with hematocrin and oosin, such as pathology or histology, to visualize the bacilli. Also, PCR has been used in these days for diagnosis and also for screening of the populations. What kind of a specimen can be used for PCR?
What kind of?
Tissue.
I remember they use the mucus in the nose.
Yes. It was from the nose. And also the tissue also, I give. For screening, some people may develop the disease after several years. So you can detect the carriers much earlier by PCR. So you take the specimens from the nose and do PCR. If they are positive, it is possible to see the true disease later on in the population. And for treatment, you should know what kind of drugs. This is always questions about the medication. What kind of antibiotics or anti-mycobacterial drugs can be used? Dapsons, clofazimine, rifampin can be used, and sometimes ethionamide or proteinamide. So differences between two forms of the disease exist in terms of duration of therapy. The duration for lepromatous leprosy is much longer. In lepromatous leprosy, for example, dapsons should be given to the patients for the lifetime. But in tuberculous leprosy, the treatment is shorter, for example, for 3 years. Look at the differences. This is for lepromatous leprosy. May require primary treatment for 3 years with dapsone and clofazimine. So combination therapy for leprosy consists of dapsone and clofazimine, 2 drugs, but treatment should be continued with dapsone for the rest of their lives in lepromatous leprosy. What about tuberculous leprosy? It says possibacillary or tuberculous leprosy, treated in 6 months, but it should be continued with dapsone for up to 3 years. So 6 months combination therapy means dapsone, clofazimine, and then 3 years with dapsone. You remember? The long-term treatment. And for lepromatous leprosy, it takes longer time. Lifetime. For lifetime, for the rest of their life, they should take dapsone. These people are very susceptible to be infected with many infectious diseases. Why? Because cell-mediated immunity is weakened.
Infection disease in nose mucosa and the lungs, bottom of the lungs.
Not lungs. From the nose, yes, they can transmit the disease and progress.
What more? You mean?
Mucous membranes of the nose and the skins.
They use hyaluronic acid.
Not lungs.
Hyaluronic acid for treatment for nose infection.
You learned what?
No, about
You mean about
hyaluronic acid. They use it as mucosal infections.
Hyaluronic acid for leprosy? No, I didn't have. If you have reference, just give it to me to show. Other options for treatment is IL-2, interleukin-2. So they use it and inject it to the site of infection directly. Interleukin-2 is helpful to improve the immunity. So they use it. Okay, we go to the last sessions. What's the time?